An aneurysm is a full-thickness dilation of a segment of a blood vessel so that it's 50% greater than its normal diameter, and it's usually caused by a weakness in the blood vessel wall. True aneurysms involve all three layers of the arterial wall: the tunica intima, which has endothelial cells, the tunica media, which has smooth muscle, and the tunica adventitia, which has connective tissue as well as the vasa vasorum, which are the vessels nourishing the aortic wall itself. There are two major types of aneurysms: fusiform aneurysms, which are uniform in shape with symmetrical dilatation and involves the entire circumference of the aortic wall, and saccular aneurysms, which are localized outpouchings of only a portion of the aortic wall. Most individuals with abdominal aortic aneurysm, or AAA, have no symptoms and are only detected as an incidental finding on imaging studies performed to evaluate an unrelated condition. Some cases, especially in thinner individuals, may be discovered on a routine physical examination as a pulsating abdominal mass that can be felt on palpation and heard as a bruit on auscultation. One-time screening with ultrasound can be done in individuals with risk factors like hypertension, increasing age, being male, smoking, atherosclerosis, genetic syndromes such as Turner syndrome or connective tissue diseases like Marfan syndrome or Ehlers-Danlos syndrome, familiarity with aneurysmal diseases, and having aneurysms in other arteries. Aortic dissection is defined as a separation of the layers of the aortic wall due to an intimal tear that creates a second blood flow channel. Blood may flow in between the layers of the blood vessel wall as the tear extends, which can lead to aortic rupture or decreased blood flow to the organs. Dissection in most cases is associated with a sudden onset of severe pain, often described as tearing. Aortic dissection can quickly evolve to full-thickness tearing due to the weakening of the aortic wall to the extent that it can no longer support the forces imposed upon it, leading to a complete rupture. Most cases of aortic rupture present with the classical triad of severe acute pain, a pulsatile abdominal mass, and hypotension. This may rapidly cause a massive hemorrhage, possibly evolving into shock and death. Aortic aneurysms are classified by their location along the aorta. Abdominal aortic aneurysms involve the segment of the aorta within the abdominal cavity. Thoracic aortic aneurysms are found within the chest, and these are further classified as ascending or descending aneurysms. Finally, there's thoracoabdominal aortic aneurysms, which involve both the thoracic and abdominal aorta. AAAs are the most common form of aneurysm, usually involving the infrarenal segment of the aorta, inferior to the renal arteries and superior to the iliac bifurcation. A AAA is defined as dilation with a transverse diameter exceeding 3 centimeters. Symptoms of a AAA include abdominal pain that can radiate. For proximal aneurysms, there's upper abdominal or back pain, and for distal aneurysms, there's lower abdominal or pelvic pain. The pain is typically unrelated to movement or body position. Unruptured aneurysms typically present with an indolent onset of pain that's vague and nonspecific, while ruptured aneurysms cause sudden onset severe pain. AAAs that cause symptoms may be about to rupture or may have already ruptured, and so all of them are considered medical emergencies. Aneurysms can cause turbulent blood flow, and that can lead to vessel wall damage, areas of stagnant blood flow, and the formation of thrombi. Thrombi can also embolize to various sites, causing symptoms like claudication, painful blue digits due to recurrent focal ischemia, known as blue toe syndrome, or a painful pulseless cool extremity due to acute limb ischemia. Rarely, AAA can lead to acute aortic thrombosis, leading to bilateral lower extremity ischemia, or spinal cord ischemia. Finally, large aneurysms can cause local compression of nearby structures like the gastrointestinal tract or the spine. A definitive diagnosis of AAA requires seeing a focal aortic dilation on imaging. Small aneurysms have a diameter smaller than 4 centimeters. Medium aneurysms have a diameter between 4 and 5.5 centimeters, and large aneurysms have a diameter larger than 5.5 centimeters. Based on prior imaging, a rapidly expanding aneurysm is defined as one that grows more than zero point 0.5 centimeters per year. For symptomatic individuals, a diagnosis of AAA is guided by their hemodynamic status. Hemodynamically stable individuals with symptoms of AAA should get an urgent abdominal CT scan with contrast. CT scan findings consistent with a ruptured AAA include a retroperitoneal hematoma, indistinct aortic walls, retroperitoneal fat stranding, loss of the fat plane between the aorta and the surrounding tissue, and extravasation of IV contrast outside the aorta into the retroperitoneum, into a vein, or even into the bowel. On the other hand, findings that may be associated with potentially unstable aneurysms or impending rupture include a crescent sign of layering hematoma within the aorta, aortic blebs that bulge from the surface of the aorta, draping of the aorta over a vertebral body, irregularity of the aortic wall, breaks in the calcification of the aortic wall, and localized areas of higher attenuation within a mural thrombus. Now, in hemodynamically unstable individuals with symptoms of a AAA, they should be taken right away for surgical management. On the other hand, if it's not clear that they have an aneurysm, then a bedside ultrasound should be obtained. The treatment options for asymptomatic AAA include conservative management, surveillance with a plan for eventual repair, and immediate repair. Conservative treatment involves management of modifiable risk factors like smoking cessation, antihypertensive therapy to control blood pressure, statin therapy to lower cholesterol levels, and antiplatelet therapy for cardiovascular disease. Asymptomatic AAA smaller than 5.5 centimeters in diameter should be followed up with annual ultrasound with periodic clinical evaluation and surveillance of aneurysm diameter. Repair is recommended if the aneurysm is or becomes bigger than 5.5 centimeters or is rapidly expanding, which is defined as an increase in maximal aortic diameter of 5 millimeters or more over a 6-month period of time, or more than 1 centimeter over 1 year. For a symptomatic unruptured AAA of any size, urgent AAA repair should be performed, because the presence of symptoms suggests that the aneurysm is rapidly changing and might rupture. A ruptured AAA can be fatal and needs emergency repair. For individuals with ruptured AAA, the systolic blood pressure should be maintained between 80 and 100 millimeters of mercury prior to repair, which is known as permissive hypotension, to minimize further tearing of the aorta and reduce blood loss. There are two modes of repair: open aneurysm repair and endovascular aneurysm repair, or EVAR. Open aneurysm repair involves replacement of the diseased aortic segment with a prosthetic graft through a midline abdominal or retroperitoneal incision depending on the location of the aneurysm. The dilated portion of the aorta is open for insertion of a synthetic graft. Once the graft is sewn into the proximal and distal portions of the aneurysmal sac is closed around the graft to avoid adhesions or fistulization, especially with the duodenum. On the other hand, EVAR involves the placement of an expandable stent graft through the iliac or femoral arteries to line the aorta. Sealing of the device against the aortic wall is achieved proximal and distal to the aneurysm, excluding it from the systemic circulation. However, to perform EVAR, the individual must meet some specific requisites. Firstly, there have to be stable proximal and distal aneurysm necks, both long enough to ensure that the stent graft seals. 1.5 centimeters of neck is generally what's needed. In addition, there must be no thrombus or calcification of the aneurysm, no occlusion of the iliac or femoral arteries for access, and the individual can't be affected by connective tissue disorders, since that means they have weaker arterial walls. Moving on to thoracic aortic aneurysms. They're defined as a permanent localized dilation of the thoracic aorta, having at least a 50% increase in diameter compared with the expected normal diameter for that aortic segment. They're divided into the ascending thoracic or the descending thoracic, depending on whether they're proximal or distal to the origin of the left subclavian artery, respectively. Thoracic aneurysms are often asymptomatic and discovered through chest radiography done for other reasons. The most common features include a widening of the mediastinal silhouette, enlargement of the aortic knob, or displacement of the trachea from the midline. Other radiographic features include displaced calcification, aortic kinking, and opacification of the aortopulmonary window. These findings should prompt further evaluation, since many aneurysms are not apparent on the chest radiograph, and chest radiography can't reliably distinguish an aneurysm from a tortuous aorta, which is a twisting or distortion of the aorta that causes narrowing or constriction, potentially blocking the blood flow. CT angiography with IV contrast, or an MRI, should be done to identify a thoracic aneurysm, determine its size, define aortic and branch vessel anatomy, and rule out a rupture or dissection. Symptoms generally arise only when the thoracic aneurysm has expanded enough to cause compression of nearby structures, leading to chest, back, flank, or abdominal pain. Depending upon the aneurysm location, other symptoms can also occur, including hoarseness, diaphragm paralysis, wheezing, cough, hemoptysis, dyspnea, or pneumonitis. Compression of the superior vena cava can lead to superior vena cava syndrome, which presents swelling of the neck, face, or upper extremities. Patients can also present with acute neurologic complaints due to aneurysmal compression of aortic arch branch vessels or arterial thromboembolism. But again, the most serious complications are aortic dissection and rupture, which is associated with severe pain and hypotension or shock. Individuals with asymptomatic thoracic aneurysms should be followed with serial CT or MR angiography studies. The first imaging follow-up should be done 6 months after the initial study that identified the aneurysm. If the thoracic aneurysm demonstrates rapid expansion or is above the diameter threshold for repair, imaging should be done every 3 to 6 months. Rapid expansion is defined as more than 10 millimeters per year for those with sporadic, degenerative thoracic aneurysms, meaning it's not associated with genetic syndromes, and 5 millimeters per year for those with genetic syndromes. Regarding diameter threshold, for those with sporadic degenerative thoracic aneurysm, the threshold for elective repair of ascending thoracic aneurysm is an end diastolic diameter of 5.5 centimeters, while that of descending thoracic aneurysm with a low risk for perioperative complications is a diameter of 5.5 centimeters, and for higher risk individuals, it's 7 centimeters. On the other hand, the diameter threshold of thoracic aneurysms associated with genetic syndromes is 4 centimeters. Now, if the thoracic aneurysm does not expand after 6 months and is below the diameter threshold for elective repair, imaging follow-up may be done once a year. Conservative treatment should also be done to manage risk factors such as smoking cessation, antihypertensive therapy to control blood pressure, statin therapy to lower cholesterol levels, and antiplatelet therapy for cardiovascular disease. Now, once thoracic aneurysms become symptomatic, emergency surgical repair is indicated regardless of aneurysm diameter to minimize the risk of rupture. That's if the rupture hasn't already occurred. Descending thoracic aneurysms can be repaired with an open or endovascular approach. The choice depends on whether the etiology is sporadic or genetically mediated. Sporadic descending thoracic aneurysms may get endovascular approach for initial repair, provided the thoracic aortic anatomy is suitable for endografting. And since we're in the thoracic aorta, the equivalent for EVAR is called thoracic endovascular repair, or TEVAR. An ascending thoracic aneurysm is managed with an open surgical approach using a form of extracorporeal circulation called a cardiopulmonary bypass, meaning it temporarily takes over the function of the heart and lungs during surgery. The machine pumps the blood and, using an oxygenator, allows red blood cells to pick up oxygen, as well as allowing carbon dioxide levels to decrease. Alright, as a quick recap. Aortic aneurysms are usually asymptomatic and are discovered incidentally while performing an imaging study for an unrelated condition, generally ultrasound for AAA and chest radiography for thoracic aneurysms. Risk factors are an indication to perform periodic screenings, and they include hypertension, increasing age, being male, smoking, atherosclerosis, genetic syndromes, familiarity for aneurysmal diseases, and having aneurysms in other blood vessels. Dissection, in most cases, is associated with a sudden onset of severe pain, often described as tearing. Aortic dissection can quickly evolve to a complete rupture. Most cases with aortic rupture present with the classical triad of severe acute pain, a pulsatile abdominal mass, and hypotension. This may rapidly cause a massive hemorrhage, possibly evolving into shock and death. To avoid this, asymptomatic aneurysms should get conservative management, which includes smoking cessation, antihypertensive therapy to control blood pressure, statin therapy to lower cholesterol levels, and antiplatelet therapy for cardiovascular disease. In addition, they must be followed up with imaging to evaluate the diameter and expansion rates. Above a certain diameter threshold or expansion rate, the aneurysm should get elective repair, which can either be open or endovascular aneurysm repair. For AAA, repair is recommended if the aneurysm is or becomes bigger than 5.5 centimeters or is rapidly expanding, which is defined as an increase in maximal aortic diameter of 5 millimeters or more over a 6-month period of time, or more than 1 centimeter over 1 year. For thoracic aneurysm, rapid expansion is defined as more than 10 millimeters per year for those with sporadic degenerative thoracic aneurysm, and 5 millimeters per year for those with genetic syndromes. Regarding diameter threshold, for those with sporadic degenerative thoracic aneurysm, the threshold for elective repair of ascending thoracic aneurysm is an end diastolic diameter of 5.5 centimeters, while that of descending thoracic aneurysms with a low risk for perioperative complications is with a diameter of 5.5 centimeters, and for higher risk individuals, it's 7 centimeters. On the other hand, the diameter threshold of thoracic aneurysms associated with genetic syndromes is 4 centimeters. Finally, symptomatic aneurysms should always get surgical repair regardless of their diameter.